All right, let's talk about one of the most common and, frankly, most challenging things you're going to face in the clinic or on the wards: cognitive impairment. We're going to build a really practical, high-yield framework you can put to use like tomorrow. Okay, so let's just jump right in with a super common scenario. You're in clinic, and an older patient comes in with their family. They're worried. They're saying, "Doc, mom's just not herself. She's forgetting things." I mean, you're going to see this all the time. So, where do you even begin? How do you start to organize your thoughts? First things first, before we even get to the diagnosis part, we need to get our terms straight. Cognitive impairment just means a loss of function in some part of the brain, memory, language, whatever. But here's the absolute key distinction. It becomes dementia when that loss gets bad enough and keeps getting worse to the point where someone can't function on their own anymore. That's the line in the sand. All right, so let's get down to brass tacks. How do you go from that worried family in your office to a real systematic workup? This part is huge. It's the foundation for everything that follows. You really have to nail this. So thankfully, we have a great roadmap from the American Academy of Neurology. Just think of this as your 5 essential steps for every one of these patients. You've got to do a good neuro and cognitive exam. You have to screen for things that can look like dementia, like depression. And this is a big one. You have to go through their entire medication list. Polypharmacy is a huge, huge problem. And then, of course, you get your basic labs to look for reversible stuff, and you get a picture of the brain with an MRI or CT. Okay, so once you've got that initial workup going, you can start thinking about your differential. And honestly, the best way to wrap your head around this is to divide the possibilities into 2 main buckets. Let's start with the first bucket. These are the dementias where the main story is about thinking or behavior. Big motor problems, they haven't shown up yet. And this right here, this picture tells you pretty much everything you need to know about the number 1 cause, Alzheimer's. Look at that. See how shrunken the hippocampi are? Those are the memory centers of the brain. When you see that kind of volume loss, it makes perfect sense why the classic symptom is this slow, creeping memory loss that just gets worse over time. Now, this is where being a good clinical detective comes in. How do you tell Alzheimer's apart from something like frontotemporal dementia or FTD? It all comes down to the first thing that goes wrong. In Alzheimer's, it's memory. But in FTD, it's a huge shift in personality and behavior. And check this out. The insight piece is so important. Someone with early FTD might ace your cognitive tests in the office, but their family will tell you their life is a mess at home. Why? Because they have absolutely no idea anything is wrong with them. And, just like we saw with Alzheimer's, the scan tells the story for FTD too. This is the why. Look at that. All the damage is right up front, in the frontal lobes. Think of the frontal lobes as the CEO of your brain. They handle personality, judgment, social skills. When they're damaged, you get exactly what you'd expect. People who are disinhibited, apathetic, and just make awful decisions. All right, time for our second bucket. This is a whole different ballgame. We're now talking about dementias where motor problems aren't an afterthought that shows up years later. Nope. Here, the motor symptoms are front and center, right from the beginning. Sometimes they even show up before the cognitive stuff really kicks in. The poster child for this category is dementia with Lewy bodies, or DLB. And if you're trying to tell it apart from Alzheimer's, it's all about timing. In Alzheimer's, motor problems are late finding. In DLB, Parkinsonism, the slowness, the stiffness, the shuffling gait, it's there early. And you've got 2 other massive red flags to look for. 1, vivid visual hallucinations, and 2, these crazy fluctuations where the patient is fine 1 hour and totally out of it the next. So to spot DLB, you're really looking for that core trio: Parkinsonism, the fluctuations, and the hallucinations. Oh, and here's a pro tip. Always ask the family if they're acting out their dreams. That's REM sleep behavior disorder, and it's a big clue. But listen, if you only remember one thing from this whole explainer, make it this. These patients can have a catastrophic reaction to antipsychotic meds. You have to be so careful. Okay, now we're going to talk about a diagnosis that you cannot miss. Why? Because unlike pretty much everything else we've talked about, this one might actually be treatable. We're talking about normal pressure hydrocephalus, or NPH. And the way to spot it is with its classic triad of symptoms. The mnemonic that's been around forever is wet, wobbly, and wacky. And honestly, it sticks for a reason. Wobbly is the gait. It's the first and biggest thing you'll see. People call it a magnetic gait because it's like their feet are stuck to the floor. Wet is the urinary incontinence, and wacky refers to the cognitive slowing. Wet, wobbly, and wacky. Don't forget, but, and this is a huge but, you can't just diagnose NPH based on the symptoms alone. It's not enough. You absolutely have to see this on the brain scan. Ventriculomegaly. The ventricles, the fluid-filled spaces in the brain, are just way bigger than they should be, even for the patient's age. Without that finding on imaging, it's not NPH. And the last one we'll touch on in this bucket is vascular cognitive impairment. Your spidey sense should be tingling for this one in any patient who has a history of strokes or a ton of vascular risk factors, high blood pressure, diabetes, the usual suspects. Their brain scan often looks just like this, with all these white matter changes from damage to the small blood vessels. And clinically, what do you see? A lot of the time, it's cognitive slowing and gait problems that show up early on. Whew, okay, that was a lot, I know. We've run through the biggest players in the dementia world. So now let's do the most important thing. Boil it all down into a super high-yield summary that you can actually use when you're seeing patients. Think of this table as your cheat sheet. You see a patient, you just mentally run down the list. Is memory the first and main problem? Think Alzheimer's. Is it a huge personality change? That's our clue for FTD. Are they fluctuating with Parkinsonism and hallucinations? You gotta have DLB on your list. Is it that wet, wobbly, wacky triad? Think NPH. And if they have a ton of vascular risks and are slow with gait problems, well, that points toward a vascular cause. And let's wrap up with 4 clinical pearls that are basically rules of the road. Number 1, for mild cognitive impairment, or MCI, we have no approved meds to stop it from getting worse. Number 2, and I'm saying it again because it's life or death important, be incredibly careful with antipsychotics in DLB. Number 3, got a patient you think has NPH? If you do a big lumbar puncture and their walking gets better, even for a little bit, that's a fantastic sign that a shunt will help. And finally, number 4, do not skip the basic workup, ever. Missing something reversible like a vitamin deficiency is just not an option. So, I'll leave you with this question. The very next time you're faced with this situation, a family worried about memory loss, what are the first 3 things you're going to do? Really think about it, because when you're dealing with something this complicated, having a solid framework, well, it's not just helpful, it's absolutely everything.